my goal is to make this be like incredibly informal because it's a pretty small audience, and so if you guys have questions, make sure you let me know. I'm going to probably hand out a few things, implants and that sort of stuff, which we have. If you get any of those, make sure give them back because we use them for some practice stuff and whatnot here. So, so we're going to talk about joint replacements, and I mean the overall kind of premise of this discussion is really talk about joint replacements, but there's a lot of other stuff in here. I basically try to make it to where I'm like throwing out some information that either I feel like that I hope will be useful to you guys. And so it's not all on joint replacements. There's some medical management things, that sort of stuff in here for osteoarthritis, and some surgical tips for FHOs and that sort of stuff. So anyway, the goal of the presentation, I'm going to start off talking about hyaline cartilage. I've given, I've done lectures that are similar to this in the past, and every time I start doing them, I end up reading about hyaline cartilage, and I just get amazed every time I read about it because it's such a real specific tissue, and it's just amazing to me. So I hope I'm not boring anybody with that, but I'm going to review what hyaline cartilage looks like. We're going to talk about some medical management for osteoarthritis, and then really provide a broad summary of the current state for all joint replacement options in companion animals. And there's going to be a lot of different topics here, and so it's pretty superficial. So if you have questions about anything, just stop me, please. We're going to talk more about hips than we do about elbows or knees, which are the other two joint replacements, just because that's what's most applicable. There's so much more information about hips. We're also going to talk about hip dysplasia a little bit. I'm going to walk through an FHO as far as how I do an FHO and like things that I think are important as far as how that's performed, which hopefully that'll be useful information. And then we'll just talk about what we're doing here as far as our total hip program goes. So to begin with, articular cartilage, it's hyaline cartilage. It's a very unique tissue in that it has no blood vessels, no lymphatics, no nerves. All nutrition comes from basically osmosis and diffusion. Has an extremely low friction coefficient, so there's really hardly any resistance to movement back and forth. The components of hyaline cartilage, basically like 80% of it is water, and we'll talk about like how that water gets in there. Chondrocytes are what do all the work as far as production of proteins and collagen. And then there's this matrix, which is what we'll talk about mostly because it's got the most complexity associated with it. The matrix, and that'll come in with the medical management of osteoarthritis because all that glucosamine, chondroitin sulfate, all that stuff fits in with the matrix. And so it helps me to understand how hyaline cartilage works or is made in order to understand why we're supplementing and how we're supplementing and all that sort of thing. This is really, from a histologic standpoint, what cartilage looks like. With various layers of subchondral bone down here, and then this is the articular surface up top. Most of it's water, but the water gets in there for a real specific reason, and it has to do with this matrix. And so the matrix of cartilage is made up of really two things, collagen and proteoglycans. And proteoglycans are just proteins that go through a specific glycosylation process. The two are the one that you've heard of is hyaluron. So your hyaluronic acid supplementation, that's where that fits in with joint injections. But then there's also another one called aggrecan, and there's more of them, more of these proteoglycans in cartilage. But these are really the two big ones. This is hyaluron here. This is hyaluron here. These are collagen fibrils, and so basically there's this like spider web of collagen fibers, and in the middle of all that are proteoglycans, and proteoglycans are really this is a proteoglycan called aggrecan here, and it's made up of this is a portion of proteoglycan, and these little arms right here are the glycosaminoglycans, and so that's where your chondroitin sulfate and your keratin sulfate come in. That they live right here, and basically these things are just very hydrophilic, and so they pull water in. have a strong attraction for water. And what that does is swells cartilage, and then the collagen fibrils they become taut and create the structure of the cartilage. So water has to come in, and then collagen gets stretched out, and that creates this substance of cartilage, and that's how you get 80% of it to be water, which is important. This is just I did a little bit of internet surfing. This is what aggrecan looks like, apparently. So it's these really bizarre looking molecules that are within cartilage, and they're pulling water in. This kind of random structure is important in that these proteoglycans, that matrix, their primary job is that they are resistant to compressive forces. So when you think about cartilage and what, like your knee, my knee, what it has to do is it has to be able to deal with two kind of forces. One's tensile, and so just joints moving across each other, and there's that tensile force. Then there's also compressive force, which is huge. And the fact that all that water gets pulled in is held, makes collagen fibers tight. And then the structure of this kind of loose structure really helps with compressive forces, which allows you to walk on your joints for years and years and years. Just more of the same explanation, basically. This is hyaluronan right here. This is proteoglycans here, and then again, this is where chondroitin sulfate, keratin sulfate, which you supplement with adequine. That's where it comes in. Again, this is just the basic structure of what cartilage works out. And when you get into a situation where you have osteoarthritis, all this stuff just starts breaking down. You have all this structure that exists, and inflammation comes in, and it just starts breaking this structure down. And if you don't have this structure, then you don't have cartilage that works. Again, this is what it looks like from a histologic standpoint. And the interesting thing here is that you have this orientation of collagen fibrils, and you really have a concentration of collagen at the superficial layers of cartilage, and then you have a concentration of this matrix deep. And the collagen fibrils, they're the ones that resist tensile forces, or shear forces going across the joint. And then the compressive ability, or resistance to compression, really comes out down here, and that's where you have your water and your proteoglycans and what live here. So I don't know. It's kind of a long, drawn out deal, but it's interesting. So we're going to just skip on to medical management, and the reason I went through the hyaline cartilage thing is just to understand some of the medical management thought process. I want to emphasize one thing here, in that the number one aspect of medical management for osteoarthritis is weight loss. I mean, there's a lot of papers out there talking about a lot of different things that it is hard to really gather useful information from, but the role of weight management in control of arthritis, predisposition to hip dysplasia, and long-term manifestations of osteoarthritis is very, very clear through multiple studies. And basically what they show is if you take animals, you make them thin, you can decrease their incidence of hip dysplasia by about 65-70%. And if you take thin animals, follow them out, match them up with animals that are a bit overweight, the overweight animals, they'll have substantially different levels of arthritis in multiple joints, and especially a large predisposition to hip dysplasia. So when people come in here, I kind of err on the side a little bit of being obnoxious, because I have people walk in the door and they'll come in and they're getting ready to spend $2,000, $3,000, $4,000, $5,000, and I will be real blunt with them if they come in with a fat dog. That I know they love their dog. I know they'll do whatever has to be done for their dog, and so I'll really get on them about weight management. I have no idea if that's helping, because you guys are the ones that are dealing with it. But I really emphasize that because that's clearly been shown to be extremely important. Well, I mean, yeah, you do. I mean, I try not to match them up, because a lot of times they can go hand in hand, and I err a little bit towards, like, I mean, they might walk out aggravated, but I know it's the right thing for their dog, and most people, they seem to get it. I wanted to point out this right here, in searching around, I found this website, petobesityprevention.com. This is a website that's been put together. There's probably 25 veterinarians that are associated with it. So like Dr. Barges down at UT's on it. It's really headed up by a general practitioner out of North Carolina. But there's surgeons, endocrinologists, internists, nutritionists that are involved with this website. And it provides useful information to clients and to veterinarians, I think, as far as dealing with obesity issues in animals. You know, a couple of things that were interesting. You know, they have templates for some basic paperwork that you could give out to clients and say, all right, let's talk about weight loss. You know, it gives them forms to fill out and follow progress over time. You know, they have daily eating and activity charts. And so instead of you having to make these things up, you just print them off and say, here it is. The other thing that is really good on this website is they have basically every pet treat, every cat treat, every dog treat, every dry dog food, every dry cat food, every wet cat food and dog food, and they have the caloric density of it listed for you, which is something I'm always, they're like, I eat this food, blah, 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 how much should I feed? And this website, they have an endless supply of these sheets. So I would highly encourage everybody to write that down right there, because I know that for me, I'm talking to clients and they're talking about weight loss, and it involves a little bit of effort to get them information about how much a dog should be eating. So, other components of medical management. I mean, this is my generic recommendation to a client coming in the door when I talk about medical management for arthritis. You know, weight management we already talked about. NSAIDs, I basically tell people that, you know, there's a lot of good options, and, you know, it's a matter of personal choice and then really monitoring an individual pet's response, just like it is in people. I generally push people away from using aspirin. I mean, there are people that use it, and, you know, that's their choice for sure, but I will tell them there are much better options than aspirin for pets. And then chondroprotectives. So, you know, we reviewed the hyaline cartilage, probably too much. But, you know, so I added that so this would really make sense. So glucosamine is it's a monosaccharide, and so this is really the subunits of what goes in to make glycosaminoglycans, which is chondroitin sulfate. So this is the subunit for these guys, and then chondroitin sulfate, you know, is a big part of, or it links up with hyaluronan. So it's just that microscopic molecular structure of cartilage. Whenever you're supplementing with these chondroprotectants, the general concept is that there's an inflammatory process going on in the joint, and I mean, that's going on when you have arthritis. You always have, like as we sit here, we're breaking down cartilage, we're building up cartilage, and so there's a metabolism that has to maintain this homeostasis, and part of the thought process behind osteoarthritis is that just gets out of whack, and you're degrading more than you're building. And so when you supplement with chondroprotectives, all you're doing is over-supplementing with the building blocks of cartilage. That's the primary thing you're doing, and that's through glucosamine and chondroitin sulfate and hyaluronic acid. These compounds are also reported to have anti-inflammatory effects, oxygen-free radical scavenging abilities. So they have some primary anti-inflammatory, but the general concept is that you're supplementing with the building blocks of cartilage. Activity and muscle maintenance. I just tell people, I tell people that it's really variable depending on individual dogs, and I tell people to watch their dog. Like, I have a dog that has hip dysplasia. She's about 14 now. I've never done anything with her other than intermittent medical management because she's had an incredibly high level of function. She's just one of those go dogs. And so with her, now she's so old she really doesn't chase ball anymore. But that was, we chased ball, hours and hours and hours of ball chasing. And so just regular activity that they really enjoy, and if something that they can do, with some endurance, then generally I think it's a good thing. In general, the recommendation is to avoid highly concussive activities, jumping up for frisbees, jumping off, deck stairs, etc. We already talked about this again. Just this is the logic behind supplementation with these chondroprotectives. Okay, so that was a little blurb on medical management, cartilage anatomy. And And so now we're going to move on to talking about joint replacements. These are the 3 joints that are currently replaced in dogs or cats. Knee, elbow, and hip. The hip is all capitalized because it has got the lion's share by far. I mean, the other 2 are not even close. But that's what is feasible as of right now. With each of these, what I am going to do is just go through a timeline. And basically with knees and elbows, there's not a lot of information. And so there's like 2 or 3 papers on each one of them. I have a lot of people that come to me and they'll ask, can we do an elbow replacement? Can we do a knee replacement? This has been a really good review for me because I feel like I've got a solid handle on where we are currently. And I hope that you guys can walk out of here and have a pretty good handle too. So the canine knee replacement, the first report was in 1982. And the reason this is so early is just because knee replacements are so common in people. And so this is an animal model that was looking at an application to learning something about human knee replacements. That's about the same time that the first hip replacement occurred in dogs as well. And then really nothing at all happened until 2007. In 2007, there's really one guy in the country that does these with any frequency, a guy named Bill Liska. He's in Houston, Texas. And he and Denny Marcel Little, who's over at NC State, they basically had this one, they must have had a client who's like, I love this dog, I don't care what it takes, I want to figure it out, And they had a dog that had a femoral non-union associated with, I think, a distal femoral physeal fracture. And so they ended up with this one dog going and making custom implants for it, doing all this 3D CT reconstruction, making bone models, etc. And they were able to put a knee replacement in this dog. And in 2007, they reported on that. And they basically said, we could put it in, the dog got better, still kind of lame, but overall using the leg okay. And then in 2009, there were 2 case series that were reported. This one is, actually I think I've got the papers, what it is. So in 2009, there's a case series of 6 dogs that are reported by this Bill Liska out of Texas. And he basically had 6 dogs that did total knee replacements on. This was totally, they were basically just making it up as they went. They used biometrics, which you'll see through here with some regularity as far as the development of the implant design. They based a lot of stuff off people, and they put 6 total knees in. These were dogs basically that had terrible function of their leg, and the owners were at the point where they were either saying, we're going to have to do an arthrodesis or we're going to have to amputate. And so it was kind of a no-lose situation for them. So what they were able to figure out is that you could do it. And they followed all these dogs out for 1 year post-op. And basically all of them, there were no catastrophic failures. There was nothing terrible that happened. All of them had improvement. They did a force plate analysis on them, so they looked at how much weight they would put on the leg afterwards. They showed that improvements in force plate evaluation. They did not go back to normal function by any stretch of imagination, but they had improved range of motion, increased weight bearing. And they followed them up for 1 year, and nothing terrible happened. And then in the same year, out of Ohio State, there are 24 research dogs, and this is kind of the model of how it works. They'll have clinical series where they deal with animals that have clinical disease, and then they'll also take normal dogs and figure out, can they do these joint replacements in them. And so in 2009, 24 research dogs that had normal stifles had knee replacements performed. They followed them out for 1 year. They did serial radiographs over time, and basically they showed that visible lameness was gone by 12 weeks post-op, and there's no pain by 6 weeks post-op. They did not do force plating, which I'm not really sure why. They had a persistent mild decrease in range of motion, and they had some decreased thigh circumference. So they couldn't take these dogs back to normal function, which is basically what we're expecting out of hip replacements, but they were able to have them function. They took all these implants out. They did biomechanical testing on them to see if they were loose at 1 year. They were all, there was one femur that was loose, but mildly. But what they did show is that all the tibial implants, and the tibia is a polyethylene, so it's a plastic. All of them were starting to wear, and that's one thing when you look at joint replacements overall. You have to look at longevity of the implants, and basically they start getting these wear particles, and the plastic starts breaking down in them, which is associated with an inflammatory reaction, and that's associated with a lack of longevity for implant or joint implants. So that was of some concern.
Is this something more concerning our dogs versus human beings, though?
Mm-mm. No, I mean, all this stuff is based off people. I mean, in people, you really have to avoid wear particles at all, for sure as well. And, in people, which in none of these joints do we have information about really long-term follow-up. That is very true for elbows and knees. With hips, there are plenty of animals that are out greater than 10 years, but there aren't a whole lot of papers really look at those dogs 10 years out. In people in general, you say get a joint replacement, it's going to last you about 10 years if it works well, and so they know that there's going to be some turnover associated with that, and wear particles are part of that issue. So in summary, basically knee replacements are feasible in normal dogs and dogs with severe stifle disease. Very few cases have been reported, so we have like 26 that I found. This is something that'll pop up as well, is that Biometrics and Arthritis basically are making components of joint replacements, and so on their website they report that there have been 300 that have been performed. I don't know if that just means they've sold 300 sets of implants, but those are definitely not reported, but that's what they're saying have been implanted since 2005. And with the knees, there basically is only one system that exists. When we talk about the elbows, you're going to see there's actually 3 different systems that have been described. We have no information on long-term prognosis at all. And again, Biometrics is working to create instruments and modular implants and basically trying to create a market. And then we also know that, like, in people, knee replacements, every time I turn around, I'm talking to somebody that's had a knee replacement from a human standpoint. I don't think that really was the case like 10 years ago, but it seems like it certainly is now. And so based on the fact that they're so commonly performed in people, and based on what I know from this now, I would predict that there probably is going to be continued evolution in knee replacements for dogs over time. So elbow replacements. The timeline here is actually a little bit longer. The first cases were reported in 2001. With knees and elbows, there's basically like 1 or 2 people that they just decided, I'm going to try to make this work. And this elbows is a guy named Mike Kazanemius, who used to be at Iowa State. Now he's at Minnesota. So in 2001, he had a case series of 6 dogs, and these are research dogs. And then there's a case series of 20 clinical patients. This is the entire extent of information that exists on elbows, basically. This is one system which I'll describe to you. There's another system called the Tate elbow, which I think we have just a picture of, which was developed by a guy in Ketchum, Idaho, but there's a general practitioner out there that he's like, I'm just going to figure out how to make an implant for an elbow replacement. He's done that, and he's got Biometrics that's making them. And then this is the most current evolution of elbow replacements. And again, we're going to talk about all these, but this is a unicompartmental elbow replacement, which means just the medial side of the elbow is replaced. So this is the 2001 study, 6 normal dogs. This is quite different outcomes than the knees, and the big picture here is that a lot of potential for catastrophic failure. So they had 6 normal dogs, just like they had the normal dogs for the knees, but 3 of them had catastrophic failure. One of them never used the leg, one fractured an olecranon, one had severe osteomyelitis, and so these guys totally out of the picture. Of the 3 that were left, I said they had 82% of normal function at 6 months out based on force plate analysis. They basically went through and said, yeah, we could kind of do it, but we're not really happy with it, and they made some recommendations as far as modification of the procedure, and said, this is kind of interesting, but definitely nervous. And then 2003, They moved through the process. They did 20 clinical cases. They followed these guys out for 1 year. These are animals with severe elbow disease. They reported 16 of them were satisfactory. All dogs had increased weight bearing but still used the unoperated limb primarily, which they don't really go into like what the status of the unoperated limb was. But the big thing is here, the authors concluded that the technique needs more modifications and should be reserved for only animals with the most severe disease. And so that's kind of like everything that came out of this is like, yeah, it's feasible. There's some major problems with it. And they would not consider it on a dog that just doesn't almost have no other options. So kind of like with the knees where it's like the elbow's so bad that you're either going to have to fuse it or you're going to have to amputate it. That would be the point to consider this theoretically. So this is the other system, which there are no papers on this at all, but in 2008, this guy named Randy Acker, he partnered up with Biometrics, and they developed what's called the Tate elbow. There actually is a video of this, but I didn't include it because there's just nothing out there. Like, they just say they do it. They've done like 200 of them, but there's nothing out there. There's a course that teaches this. This is what's called a hinge or a fully constrained elbow replacement. And so this is two different pieces. So here's a piece and then here's a piece. And those two things rotate on one another. And so this is the humeral component, the stainless steel, and then this blue component is the ulnar, and it just does this. There's no rotation to it at all. It's just a pure hinge. And you go to the guy's website, and they talk about it very positively, but you don't hear anybody else talking about it, and there's no papers on it. It just doesn't seem like there's a whole lot of discussion right now. So I don't think that this is. I don't think it's a real great option. Although Biometrics is teaching a course, this is one thing you have to understand in the veterinary surgery world nowadays is that there are some economic interests that are coming in, and so like Biometrics, Arthritis, they're wanting to sell implants, and I feel like they're overstating things a bit based on what I've just read. So this is the third option for elbow replacements, and this is what's called a unicompartmental elbow. It's actually, they have a shortening of it. It's a CUE, canine unicompartmental elbow replacement. So this is different. This really just treats what's called medial compartment syndrome, which basically most bad elbows have medial compartment syndrome, which means it's coronoid disease. And there are no papers on this either, but there are about 10 surgeons out there. There's a guy named Jimmy Cook out of Missouri who's really heading this thing up. If you go on the Arthritis website, there is an abstract that you can find, which they have a multi-institutional study that is in progress. They're looking at doing 60 dogs. There's 10 different surgeons that they've reported some partial results on at this point, and they're basically saying 45% of them went back to full function, 45% of them had acceptable function, and then 10% or so. And so they make a statement at the bottom that says that 88% of dogs have acceptable function. This, what these two things are here is, this is the humeral component, and so this is just a little inset. And so basically you make an approach to the elbow, you open the elbow up, look at the end of the humeral condyle, and they drill out a section so that can just be inserted in it. It's small, it's just, it's the size of the end of my finger that goes into the humeral condyle. And then this is the ulnar portion that goes to oppose it, and those two surfaces just run across each other. And so again, there's really no information out there, but if there's any buzz that's going on about elbow replacements, this is the buzz that's going on currently. This concept of joint repair is applied to people. They'll do medial compartment replacement in people with knees because there's so many knee issues, and so maybe it will gain traction, but it's just, this is really just reported in 2012. But you can look in VetSurge, and they've got an advertisement in here for it, like they're selling it. So I don't know. If you hear about people doing elbow replacements right now, I think this is probably what people are doing. Okay, so summary elbow stuff. The big thing is that there is no human equivalent to elbow replacements in dogs. people don't walk on their front legs. They just don't have this. They just don't have a comparable disease process. So this is totally just uncharted territory that people are looking into because elbow problems are so common in dogs. There are 3 different systems described, which in general, if you keep having more and more systems, it's kind of like cruciate disease was back in the day, and there was, let's fix it this way, let's fix it this way, let's fix it this way. And so if we just end up with 3, that means this last one probably worked. But that is different than these. There does not appear to be any momentum currently for total elbow replacement. And when I say that, I mean more of these large implants that are going in, not that Q system. And it's really, I think complications are a problem. It's just a really complex thing to think about trying to replace an elbow joint because you have 3 different bones, you have a hinge mechanism, and you also have rotational forces that occur. And so I think it's a lot to ask. And then this unicompartmental replacement is under early investigation. Okay, so that's all the stuff on anything other than hips. So now we'll move on to hip dysplasia, and there's a whole lot more information on this. So the slide really just says what are the big points about hip dysplasia, and first big point for me is that it's just really common. I mean, there's so many more dogs than we ever even know have hip dysplasia that have it. And the second big point is that hip dysplasia has such a variable manifestation. So you can see some dogs that have terrible hips radiographically and they function really well. Then you have other dogs, the radiographs don't look too awful bad and they can't hardly get up. And so there's just a lot of variability as far as how hip dysplasia manifests in dogs. There is a window of opportunity that exists with surgical options, and we're going to talk about this quite a bit more here coming up. There are several surgical options that exist for hip dysplasia based on these windows of opportunity. And I think the conversation with owners of young dogs is relatively complex because you've got multiple surgical options, you've got variable manifestation, you don't know how it's going to play out over time. So it's a bit of a complicated discussion to me. This addresses that one point we talked about, which there is a window. And who has heard of a juvenile pubic symphysiodesis? Everybody? So probably not. This is a really good surgical procedure right here that has been around for about 15 years, but it is not applied very much. I'm going to explain each of these very briefly, all these procedures as we go forward. But there's a window when you're looking at dogs that have hip dysplasia. There's a very early window of, it's basically really 5 months when this procedure can be applied. The one that most everybody's familiar with is the triple pelvic osteotomy. That's basically a 6-month to 14-month window with a heavy leaning towards 6 months as opposed to 14. And then once dogs get over 12, 14 months of age, these options are pretty much gone. And so then you start talking about FHOs, total hips, and medical management. So I find myself in exam rooms with some frequency talking to clients about, I got my young dog, I think that's hip dysplasia, what can I do? And the first thing that I really try to, I think an owner's impression of overall function is very important. I think owners are not really good at assessing how well their dogs are doing. But for me, it's very important anytime I'm considering any sort of surgical option for hip dysplasia is that I need to know, like, what's an owner thinking? Like, do they think their dog has a problem or not? Which most of the time when they come here, they do. But I need to know if they think they have a problem. One thing with dogs that have bad hips, typically if they're having significant problems, an owner will tell you they can't go on walks. People don't have the benefit of looking at asymmetry so much, but they'll describe, they just quit on these walks. They get a quarter of a mile out or a half mile and they just stop. They have decreased endurance with other pets, and they have difficulty going up. So those are 3 things that I look for a client to describe to me to say, I think this dog probably has clinical evidence of hip dysplasia. If I'm able to have this conversation with somebody that has a puppy that is less than 5 months of age, then I will talk to them about the JPS, which I've got a slide that's coming up here in the next little bit to explain that. I hardly ever get to have this discussion. And, I mean, I really feel like probably the onus is on our practice. If we really wanted to advocate for this procedure, we would need to get the word out there, because it's just not that there is this early surgical option for hip dysplasia. I am much more commonly having this discussion. And so dogs get referred over. They have something that's sending them here, either radiographic findings or a clinical description. And I'm trying to figure out, is this dog a candidate for a TPO? And the important thing here, and we'll talk about this more again, is that selection criteria are very important as far as the whether or not we can do a TPO. And then for the animals that are over 1 year, I'm basically talking about FHOs or total hips or medical management, which we're going to go into all these options further. So a juvenile pubic symphysiodesis is a procedure that was developed in like 2000, and it is similar in concept to a triple pelvic osteotomy, but very different in delivery. And so the surgical concept is that you get an acetabular rotation with growth. The procedure involves obliteration of the pubic symphysial physis here. And so you've got a puppy that's 5 months old. We've got more growth to occur over time. And the basic nuts and bolts of this surgery is that you kill the growth plate of the pubic symphysis. What that does is it locks that down, and then the rest of the pelvis keeps growing. And so it tethers it ventrally. This is what's called Acetabular Angle here. And so this is just a CT that's showing really what we're trying to accomplish. Is this is a sagittal view, a transverse view. And so this is femoral head, this is femoral head, this is acetabulum, and then this is the angle of the acetabulum here. And what's important for hip stability is dorsal coverage. So this is the dorsal acetabular rim, and you can see how when that sits over the top of the femoral head, then you've got a stable hip. And so this surgery just makes this hip joint rotate out, so where you get more dorsal coverage over the femoral head, and it creates increased stability that way. It does that again through obliteration of the pubic symphysial physis. And so one thing about this surgery, which is very different than a TPO for me, is that if I have a client that comes to me and says, I don't know if my dog limps or doesn't limp, I don't know if my dog's going to have hip dysplasia, but I'm interested in preventing that from occurring, I will perform this surgery on a dog. The reason for that is because this procedure really doesn't have a downside to it. And so it's a surgery that involves an electrocautery pin. You make an approach to the pubic symphysis, and you go and you do a thermal necrosis of the growth plate. And there's some technical aspects to it. You got to make sure you don't burn the colon or burn the urethra or anything like that. And the amount of time that you need to apply the electrocautery has been figured out. And so basically, it's a safe procedure, and it's something that can be done in really young dogs without much without much potential for morbidity. And so I will do this for dogs that don't have clinical signs of hip dysplasia, whereas I will say the opposite of that when we talk about TPOs. There have been 5 papers that have looked at juvenile pubic symphysiodesis. They came out of Wisconsin, really from like 2000 to 2005. And what this is a great series of papers that they did, where basically they just took puppies and they did the procedure on them, and then they CT'd them when they started, and they CT'd them when they finished, and they had a control group, and they showed that, yeah, it does actually rotate these dogs' acetabulum out. And then they took normal dogs, did the procedure to them as well, followed them out to see if they had any problems over a certain amount of time, and then they took a population of dogs that were predisposed to hip dysplasia, split them in half, did the procedure on half of them, didn't do the procedure on the other half of them, and they showed they cut down the incidence of hip dysplasia in that population that they treated by 75%. So that's why I say it's a great procedure. It's just there's a problem with getting it applied because It requires really proactive communication. So usually, I mean, the ones that I've done, which has only been 3 or 4, have been clients that they heard about it. They had a dog that had hip dysplasia. They don't want that, and they bring them in to get this done. So
you do that based on lineage or just?
no, I would do that based on breed. So if I had and Golden Retriever, Labrador, German Shepherd, any big dog, and a client that came in to me and said, you know what, I'm worried about my dog having hip dysplasia, especially if they said something like that they had a sibling or a relative to this dog that had it or was in the line, then I'll just do it. I mean, that's the thing. Like 5-month-old dog, I mean, there are ways to evaluate the likelihood that that dog's going to have hip dysplasia. Through a pin hip, that would be the primary way. But it's hard to get all that stuff done, and so that's what I'm saying. If I have an animal come in at 5 months of age, or really it's 3 to 5 months, and the earlier the better, I'll just do it based on the fact that there is some possibility that they get hip dysplasia. The only reason I would do that is because they've studied this extensively and shown that it really didn't cause a problem, and it does decrease the incidence of hip dysplasia.
How much does it cost?
I haven't done any here. It's probably $1,200, something like that. Yeah. So.
Coupled with the neuter, really easy.
Yeah, exactly. I mean that.
Castrating at 4 or 6 months, pretty young. It's something
Yeah.
that reasonably could be done with your neuter. So you do 1 surgery.
Yeah, exactly. I mean that would be the ideal way to do it, for sure.
Any cutoff limitations pertaining to the anatomy structure of the hip and joint? You
Yeah.
get a young puppy, sometimes it's just a root test to start with.
Yep. I think.
Cut them off, so we're not going to do that.
I mean, I would still be happy to do it, but I would tone down my expectations. If I have hips that are sitting out in space, I'd tell an owner, like, okay, we can do this because we have no indication that there's any substantial risk associated with it. If we rotate the pelvis out, that's not going to be a problem. I think I would feel comfortable moving forward to that. As I'm sitting here saying this, as we go on down the additional options, like the one thing nobody's looked at is if you do a JPS on a dog, are there any complications as far as your ability to do a total hip in the future? Does that have an impact? Which I've just made that up in my head, but maybe there should be something to consider there.
Would you do that and not neuter a dog at the same time?
Would I do that without doing that? That's kind of a complicated question, because it would come into like, why are you not neutering them, and like, do they want to breed them, and then you're artificially protecting them from the manifestation of hip dysplasia over time, and so I think there's some ethical kind of concerns. Ideally, I think you would, it would be. I would be very uncomfortable if I had a breeder come to me and say, hey, do a JPS on my dog and I'm going to breed them later. That would be a little sketch. Okay, so triple pelvic osteotomy. So this is that 6 to 14 month window. The concept is exactly the same as the JPS, which is this external rotation of the acetabulum. But the big point here is that there are relatively stringent, although personalized selection criteria. You go to one surgeon, they might have a different idea about what they're willing to do in reference to a TPO. For me, if I do not have clinical signs that I can get off a physical exam, or an owner that's coming to me saying my dog is really not acting like a normal dog, then I am quite hesitant to consider doing a TPO on them, because it's a big surgery. There's there's substantial money involved, and there are some risks. They need to be the appropriate age. 14 months is pushing it. The closer to 6 months, the better. They need appropriate radiographic evaluation. And so I would pretty much say that this dog is not a great candidate for a TPO based on the fact that, he's really sitting out in space pretty good. And my subjective evaluation of the acetabulum is that it looks like it has lost some of its depth. I think we're going to get to another point. Really, again, talking about selection criteria, dogs that are candidates for TPOs, generally they can't have arthritis. They need to what you're really trying to assess in deciding if this dog's a good candidate for a TPO is what is the depth of its acetabulum. Because you're going to rotate them out to give them better coverage, but if they have a shallow acetabulum, they'll still be unstable and they'll skate around. You're really relying on the natural inherent stability of the dog's hips based on the depth of its acetabulum to have an FHO or to have a TPO work. And then the relation of the femoral head to the acetabulum, again, to your point, you take some x-rays and like they're sitting out in space, and I wouldn't even consider doing a TPO on a dog like that because you can rotate them all day long and you won't get them to sit in their acetabulum. And then the Ortolani sign is generally considered to be a important evaluation characteristic for dogs that are candidates for TPOs. And again, what you're really trying to do is assess, do they have adequate acetabular depth? And that assessment is generally done based on the quality of this clunk sound that occurs. And so, the Ortolani maneuver is you lay a dog either on dorsal recumbency or lateral recumbency with them anesthetized or heavily sedated, and you can, abduct their knee, push up through their femoral shaft, and subluxate their hip joint. So you pop their hip out, basically. And then you maintain this pressure up, straight up their femoral shaft, and then you abduct them. So adduct to begin with, and then abduct them while you're maintaining that pressure, and eventually you'll push them back into their acetabulum. And, as you're trying to do that, you're trying to assess, did that thing feel like it really set in something deep, or did it just kind of roll over the dorsal acetabular rim? They pretty much all feel like they roll over the dorsal acetabular rim to me. And so I'll use that information, especially if I can have asymmetry on sides. But it's a hard assessment for me to make. You can also look at the difference between the reduction subluxation angles, and if those angles differences get really huge, then dogs are less ideal candidates for TPOs. A TPO basically involves, it's a triple pelvic osteotomy, so it's 3 cuts. When you look at the acetabulum, there are 3 points of bone connection. So your ilium, your pubis, and your ischium. And so when you do this procedure, you cut the ilium, you cut the pubis, you cut the ischium. That isolates the acetabulum, and you can do whatever you want to it at that point. So you make those 3 cuts, and then you apply this specialized bone plate with a cut here, and then there's a cut here. That plate, I wish I should have brought one of these things, but it's basically, when you look at it, from the top down, like on this VD view, it's a plate that sits like this. It's got 2 different components to it, and so when you look at this section, there's 3 screws that are here. It's offset in comparison to that section, and all it does is the way that plate is made, when you apply it and oppose the bone to the plate, it externally rotates the acetabulum and just improves dorsal coverage. We do probably 8 or 9 a year or something like that here. So we do them, but we're pretty, or at least I'm pretty, I want to try to make sure they're a good candidate before I do them. There have been several studies looking at outcomes of TPOs, and overall, it's a good procedure. They've done force plate analysis on dogs. They've, done hundreds of dogs and looked at them, as far as their improvement in outcome. They've taken normal dogs and done TPOs on them and looked at how, how they've gone back, and they've taken dysplastic dogs and they've seen how much they've improved relative to what they were beforehand. And basically, 75 to 90% of dogs, owners are going to say, we're really happy with this. So, it's pretty close to what a lot of surgical procedures are. But again, there's this emphasis on appropriate case selection. And again, for me, I just don't do this surgery unless I've got a dog where I'm like, this dog is clinically affected with hip dysplasia, because the procedure scares me a little bit. So overall, good surgery, have to use selection criteria, and there's this window of opportunity. And we've been talking about immature dogs with potential hip dysplasia, and now the rest of this is really going to go into skeletal mature dogs. And the complexity of the discussion, for one, becomes less. It's just easier to talk about adult dogs that have hip dysplasia and treatment options than it is young dogs, because that window is basically gone. There are also fewer options, so it boils down to, for the most part, FHOs, total hip replacement, and medical management. If you look through the literature, there are some different procedures. There's a joint capsule denervation procedure, which has been reported. There's a pectineal myotomy that's been reported. So there are some other things, but for the most part, it's total hip replacements, it's FHOs, and it's medical management. So the first thing I would emphasize is that I would never consider doing an FHO or total hip replacement without doing medical management first, because dogs can have quite horrible hips radiographically, and they can still respond very favorably to medical management. And for the most part, you don't need to feel some huge rush. If you can control pain and animals' quality of life, you don't need to feel like that there is some huge rush to jump into surgery. Now, there are some exceptions to that, but for the most part, that's a safe statement. So, I always recommend that first. And then, when I talk to owners about total hips versus FHOs, I think it's a fair statement to say, well, no, it's objectively a total hip replacement is a superior surgical procedure if you're just looking at joint function in comparison to an FHO. Now, having said that, FHOs decrease pain. FHOs have fewer potential complications than a total hip replacement done, and FHOs don't cost $5,000 plus. So, this is an owner-driven decision. You can really objectify and say, what's the better procedure for most dogs? And I think, if you turned the dog into a person, you would say, give me a total hip replacement, not an FHO. But that doesn't mean that that's the right decision for all owners, because most of them just can't go there, at all. So FHO is always going to have its place. Okay, so I'm just going to talk about FHOs a little bit. And my point, this dog did not get an FHO. It got a tumor removed, but I didn't have a good picture of this. So, good joke. So my intention with this is just to go through the surgical procedure and just talk about what I do and things that I feel like are important. So this would be the typical drape-in. We wouldn't have quite this much of the abdomen exposed, but lateral recumbency, hanging leg prep, and it's going to be a standard cranial lateral approach to the hip. This procedure was developed in 1971, I learned, which was about not too awful far away from when they started doing hip replacements, and so there's just not a whole lot of history behind, or at least not described history behind surgery, because this is a really standard approach. But cranial lateral approach to the hip, basically what I do is I go in and I make sure I palpate the patella, and then I palpate the greater trochanter, get those 2 points down, and then your incision is going to be coming pretty much straight over the greater trochanter here, and you're ideally going to be going just on the cranial edge of the biceps femoris muscle. So the biceps femoris comes, it's on the caudolateral aspect of the leg, and you can feel the cranial edge of it most of the time. And so the approach is right in front of that. It's important to make sure you're in front of the biceps femoris, because if you're not, you're cutting through that muscle, and it's just going to bleed, and it's going to be difficult. I think this is a really important point, is that whenever you do this approach, you want to make sure you go dorsal enough. I know my tendency early on was to do this approach that really just kind of stopped at the greater trochanter, but you want to extend your incision further dorsal. If you don't, you end up feeling real constricted as far as being able to visualize things. So this is the basic incision. It's on the cranial aspect of the femur. For total hip replacements, we really head much more caudally, and I don't really, my incision will be pretty much straight up and down, not this kind of curvy aspect proximally. But again, make sure you go plenty far dorsal, which this illustrates that. And then you want to be on the cranial edge of the biceps femoris muscle, which this image is just a cone down on this area right here. And so skin incision, here's the biceps femoris muscle, which is this very broad muscle that's on the caudolateral aspect of the limb. And then on the front of it, there's the tensorofascial lata, which has 2 sleeves or 2 components to it. And so you want to find the cranial edge of that muscle, go through the first layer, and then keep going down. That's one thing. If you don't go through both layers, then you get caught up when you go proximally. So you got to make sure you get through both layers of the tensor fasciae lata. Very, very important. And then this is just kind of jumping forward to where you get up to the point of, I mean, here's the greater trochanter here. You have your deep gluteal and superficial gluteal muscles that come in here, and they have that focal tendon that comes down and inserts on the greater trochanter. I mean, for people that haven't thought about it a while, that greater trochanter, it's just the insertion point of all the gluteal muscles, and they come down to a very fine point there. And so typically you do this partial tenotomy. It's like an L-shaped incision that will help your exposure as well. And then the femoral head is right here. One thing I think is important is when you're making this approach to go in and manipulate the leg and externally rotate the femoral head, because much of the approach is just based on feeling. So like you're like, oh, there's the head, and you just dive down to where that head is. I think if you don't do that and you hadn't done this a whole lot, you can get lost. So this is just a deeper layer of that as well. Here's the femoral head, the incision into the joint capsule. So you get there. You might know what this instrument is. Hat spoon. Does it say it right there? Oh, my bad. So the hat spoon, we use them all the time. You can cut the ligament of the head of the ligament of the femoral head with Mayo scissors, but this instrument is much more effective at doing that. And I think that it can be a challenge to get that cut, and then it can be a challenge to know that you have it cut. I mean, we still struggle with that sometimes, of going in and you make an approach to the joint, you go in, you cut the ligament of the head of the femur, you externally rotate, and you think that you've got it all cut, and then you make your osteotomy, and then you're like, oh, I'm not all the way out. And so if you can at all make sure you get all the way through that ligament, it will facilitate the surgery, because what it does is it allows the femoral head to come up more superficial for you. If you don't, then you're kind of tethered down in there, and it's hard to have the exposure that you want. So that's a pretty inexpensive instrument. It's useful. I think it helps. The other is if you're doing FHOs by yourself, which I imagine most people are, and we do sometimes as well. Gelpies really help you to get down into the joint, at that point. I do think it's a good idea to have somebody assist you for at least part of this, and so you can typically get your approach done, and then once you're ready to make your cut, have an assistant come in, just put on a pair of gloves, and just have them grab the foot, or have them, however you drape in, and have them externally rotate the leg. And basically what you want to do, when you make your femoral neck cut, you want to have the patella pointing straight to the ceiling. That's what turns your femoral head and neck around to where you've got a perfect kind of silhouetted view of it. If you don't do that, it's hard to see it. And so it's hard to make a cut if you don't get the ligament of the head of the femur completely transected, and it's hard to make the cut if you don't have somebody that can help you externally rotate that leg. And they can do that without being scrubbed in, for sure. So rotate the patella straight up and down, cut that thing. And then as far as the level of the cut goes, this has been evaluated pretty clearly, and this is really the ideal cut right here, where you're removing all of the femoral neck and you're coming just above the lesser trochanter. The lesser trochanter is the insertion point for the iliopsoas muscle. The iliopsoas muscle is what goes up, it's sublumbar, so it goes up just under the spine, and it is one of those, it is a strong attachment muscle for the rear limb to the body, and it's in a different plane than all that trochanteric musculature is. So if you can keep that attached, you maintain the iliopsoas, and that helps to improve function associated with FHOs. I feel like physical therapy is probably more important for FHOs than any other surgery that we would do here. The reason for that, if they don't get out there and start using that joint, maintain a range of motion, they'll get fibrosis across there, and so you want to be very aggressive very early. we've got a few physical therapy options in Nashville. This is for animals. This would be a great time to get them an underwater treadmill if they're small dogs. You can even put them in a bathtub and just have them, kind of do this. Really, swimming is much more of a front leg activity than a back leg, but it is good still. I get them out and get them walking and going like immediately, basically. Like I want them using the legs. So this is very different than other orthopedic procedures that really the focus is on activity restriction. With FHOs, it's really like you got to get them out there and have them doing range of motion exercises is important. And I think optimal function just takes a long time. That's always been my impression with FHOs, is that you see them like 6 months later, or you see a dog that's had an FHO 5 or 6 years ago, and they seem like they do pretty well, but if you follow a lot of them, or I'll get calls about FHOs that just aren't doing that well, I think it just takes months sometimes for them to really get to using it where you're pretty happy with it. I think there's a long window of opportunity for improvement to occur. So if you have one that's not coming around at 8 or 10 weeks, I think in general you don't want to be jumping into the thing about going back to surgery, but you want to be encourage them to weight bear. And then in general, this is what you want your cut to look like. You want to have a substantial component of the neck. This is all going to be dependent on what the x-rays look like, because there's different femoral anatomies for all dogs. But if you do your FHO and you have that, then you probably left quite a bit of neck on there, and that is less than ideal. So outcome, the basic reports say that for dogs that are less than 20 kilograms that they have an excellent outcome. They've done force plate analysis on dogs with FHOs as well, and they basically have taken normal dogs and an FHO on them and evaluated what they get back to. And they get back to about 75% of function over at 1 year out. The surgery definitely helps with pain. It's definitely got its place in the world. It's definitely less ideal than a total hip replacement if you're just looking at joint function. But it's a good surgery for, in certain circumstances. Again, recovery is slow, physical therapy is important, and they'll have a permanent gait abnormality, but there's a lot of dogs with permanent gait abnormalities. Okay, so timeline for the total hip replacements. So the first total hip replacement was, this is via Ohio State's website, it says 1976. Dr. Marv Olmsted, he's the godfather of total hip replacements, started performed his first one in 76 at Ohio State. The first case report is actually a case series in 1980. I can't remember what the guy's name was. I hadn't heard of him before. But he reported on like 24 total hip replacements in dogs. And it was interesting, there was one reference, and it was Piramonti's approach book was the only thing he referenced in the whole deal. He could have referenced some human stuff, but at that point there was nothing else. This was the first one. In 1990, they started looking at doing cementless total hip replacements, which this is something we're going to talk about as we go forward pretty extensively, the difference between cemented and cementless total hips. And so pretty early on they were talking about that. And now, I just did a literature search just on vet surgery. There's over 50 articles that are just on total hip replacements, and they're looking at everything from implant positioning to infection rates to application in toy breeds to post-implant fractures, cementing techniques, all kinds of very fine details. So there's a tremendous amount of information that exists in relation to total hip replacements. So indications for a total hip replacement. It's pretty much a hip dysplasia disease process. That's by far the most common reason you're going to have an animal coming in for evaluation for a total hip. But there are a number of other things. You can have, this would be a relatively common one. So, it's got an underlying hip dysplasia component to it potentially, or if you have a dog that has coxofemoral luxation and has loss of a portion of its femoral head. You'll see those occasionally. Dogs luxate their hip, and then they'll get this kind of slab fracture associated with the head of the femur, which is one of those things you really want to evaluate for when you have a dog that has a hip luxation. Do they have hip dysplasia? Do they have a fracture? And so If they do, then you can't really do closed reduction, you can't do an open reduction, and so you fall back on an FHO or a total hip replacement, and so realize that is an option. Capital physeal fractures are occasionally, once they've attained the skeletal maturity, going back and treated with hip replacements. Perthes disease, which that's not intuitively, it doesn't make a whole lot of sense intuitively, but one thing you'll see is that hip replacements are now being applied to all dogs and cats. So there's a huge kind of expansion of the technique to different size animals. And the femoral neck fracture, which, these are really complicated. I basically don't feel like you can repair them. And so that'd be a good option there. So what animals are candidates? And so for the longest time, this was just like a 60-plus pound dog issue, but there's been a solid expansion into small breeds. And so there's a paper that came out in like 2010 maybe, and it was this nano total hip replacement, and there's like 5-pound dogs. I mean, you can just do it on anybody now, which the technique's more complicated. It's still in the early stages, so there's more complications that are occurring the smaller these guys are getting, but inevitably that will continue to evolve over time. The big thing to think about with hip replacements as compared to elbows and knees is that, I mean, this thing works. Like it's a great surgery, low complication rate. It returns dogs to basically normal function. So it just works as compared to elbows, and maybe knees will be that way, but it's a joint that's very tolerated. There's one llama that has had a total hip replacement. It's kind of interesting, and cats as well at this point. So what pets are not candidates? So this dog is not a candidate for a total hip replacement. Obesity is a huge issue. The problem with it is that it makes it to where your surgical site you're working on is like this deep. And it's not just an annoyance, but it really physically becomes not possible because you have to have access to the bone. You have to be able to kind of ream down the shaft of the femur. And if you've got animals that are highly muscled, so like you take a pit bull that has an acetabular or has a femoral head fracture, that surgery gets much more difficult in these heavily muscled dogs, and the same is definitely true for obese dogs. Dogs that have concurrent neurologic disease, I've got obesity twice. Animals with bad skin, that is not a single incident problem. There's a lot of metal and plastic and cement in some instances that goes in here, and so you want to be very, very careful about infection. Animals that have neoplasia, there's one case report of an attempt total hip replacement for a proximal femoral osteosarcoma, and that was just a disaster. So that's not really applied currently. Some animals will have femoral conformational abnormalities. Let's see here. And we'll talk a little bit more about that coming along, but the femurs have to have a particular conformation in order for the procedure to work, and they basically have to be straight. I am not inclined to think about doing total hip replacement on animals that are kind of unmanageable. They need to be well-behaved animals that are controllable, because if you have complications, it can be really disastrous, and you need to be able to protect that joint at least for about 6 weeks. And then owners that think their dog is doing fine, I want to be able to make some forward progress, and I want to have a substantial amount of forward progress to do. So if I have a client after I talk to them, they're like, I'm fine with how my dog's doing, then I'm going to say, well, your dog doesn't need a hip replacement. And that's really up to an owner. So preoperative evaluation, and this is really my thoughts on this are really apply to most orthopedic evaluations, but it really just starts with a thorough history, and you want to make sure that your history fits with what you're trying to make this dog have. The reason that this is potentially a tricky situation is because you have so many animals that have they've had hip dysplasia forever, and then all of a sudden you're seeing them at 10 years, and they've had a change in their function, and you take an x-ray and you go, look, there's hip dysplasia, but they've been tolerating the hip dysplasia for a long period of time, and so you got to make sure the history fits. Typically it's going to be chronic progressive lamenesses, typically symmetrical. About 85% of dogs with hip dysplasia are going to have bilaterally symmetrical disease, and the big thing is acute changes are atypical. There are not many situations where you have hip dysplasia that you've got, a client that comes to you and says, my dog was doing great, he's 8 years old, and now he's not walking, or now he's holding his leg up. Not that could not occur, because there are some circumstances where you can have like an osteophyte shift off or something changes in the joint acutely, but that is not typical. Complete physical exam, really important, because again, lots of dogs have hip dysplasia. It's easy to attribute their problems to their hips, but there can be concurrent issues. And so first thing I do is look at their stifles, because that's by far a much more common reason that they be coming to me. And they actually have hip dysplasia, but they also have bilateral cruciate disease. One thing about the history for differentiating stifles from hips is that with knees, dogs will not want to stand up for very long. So you talk to a client and they'll say, yeah, you almost have to ask them the question, but you say, does your dog stand around very much? And they'll go, actually not, he's either laying down or he's going. So dogs that have bad knees, they don't want to stand. Dogs with hips, they'll stand. They just want to jump on a bed. So that's one thing historically that can help you to differentiate. You want to look closely for neurologic disease. So, scuffing of toenails, spinal pain, lumbosacral pain, pain going to the bathroom, tail, chasing their tail, etc. A close look at skin and ears. Any sort of chronic infectious process is going to have to be taken into strong consideration when you're considering a total hip replacement. And then again, body condition score, like we already talked about. So a dog basically will come in the door. I'll go through that process with a client. I'll go through this history, be thinking all that stuff in my head, go through the physical examination, thinking all that stuff in my head, and then if I can't find some alternative pathway to start heading down the road, then I'll go, okay, this looks like it's probably going to be a hip dysplasia dog. And so then I just go to radiographs. You don't want to have radiographs that look like this if you're thinking it's hip dysplasia, because this dog does not have that. So radiographs are a big part of the deal. And then if you're going to surgery, blood work and then urinalysis to look for evidence of urinary tract infection would be important as well. All right, so preoperative radiographs. There are, several thought processes that I will go through when evaluating film. And so the first thing, I just want to take an x-ray and go, yep, that's hip dysplasia, which this would be a good example of that. You also want to look for concurrent disease. So like this one's actually kind of a confusing one. This dog ended up having an osteosarc, but it had hip dysplasia for a long time. Something changes, that same joint explodes out, and he's got neoplasia at that point. Other things, and you want to look for subtleties, and that's especially where the history comes in, because let's say you have a dog that's 10 years old, they have this acute change. You can't find a reason for it. They don't have bad knees, you don't get lumbosacral pain, and so that's when you want to be really attuned to look for subtle bone changes or whatnot that could be going on. Lateral x-rays, you really don't get much information about hip conformation from them, but the one thing you do get to look at is the lumbosacral space, because that's a differential for dogs that have hip dysplasia. The dogs that have real limb lamenesses and can clearly be confused with hip dysplasia. You also want to look for evidence of luxation. I was talking earlier about the fact that there really is not a concern about a window of opportunity for being able to do a total hip replacement. There's one kind of caveat to that. If you have a dog that has such severe hip dysplasia that they have the predisposition to want to luxate, you need to operate those dogs before they do that, because what happens when they do luxate, and this dog's not luxated, I just didn't have an image of it. What happens is that their greater trochanter, their gluteal musculature basically shortens. So their greater trochanter gets closer to their ilium, and that muscle contracts down and lives in this kind of foreshortened state, which if you try to do a total hip replacement on those dogs, then you can't get them reduced because they're held up with this tight musculature. The other thing that occurs, and this dog has a really weird proximal femoral anatomy that is not really what I'm talking about, but you get changes in the proximal femoral anatomy. You get femoral cortical drift. So basically, you get the medial aspect of the femur, and it will drift towards midline right here. And that is inconsistent with the ability to do a total hip replacement, because really, just from a logistical standpoint, when you're dealing with the femur, a total hip replacement just involves sticking this straight thing down the femoral shaft. And if there's any curviness to it, then you can't do it. And so for dogs that have luxations from severe hip dysplasia, they get proximal femoral changes, which creates an S curve in their femur, and they get shortened gluteal musculature. So I take films to look for all those things, and then usually we'd go, okay, we didn't have those things, and then we do measurements. And so the measurements, basically, we just have to figure out what size implants to put in them, and logistically how that occurs is that we use a templating device, which there's several different kinds that you can use, but this is what we use here. So you take we take digital x-rays. You could do it without digital x-rays. Standard film works as well. But you have to have a measuring device. And so this thing has a known size associated. It's 10 centimeters from the end of this dot to the end of that dot. And so basically you take your x-rays, and then we have acetate templates, which have the different size implants on them. And then you have to kind of match up the size of the marker that's on that template plastic with the size there, and that's how you logistically figure out the size of the implant to put in. I spend a fair amount of time looking at femoral anatomy. Again, really what I'm trying to evaluate is whether or not we've got a pretty good straight shot going down the femur to be able to put the femoral implant in. What can happen, and what happens in a number of dogs, is that their greater trochanter, which is here, it's located more medially, and it's kind of down the center of the femoral shaft, which doesn't prevent you from doing a total hip replacement. You just have to take it into consideration when you're doing the procedure. Okay, so the next little bit is going to be talking about, I'm kind of pretending like I'm back in the room with an owner, and I'm explaining to them, okay, your dog looks like it's a good candidate for a total hip replacement. What does that mean? And so that conversation really starts with some of the stuff I've already told you, which, like, it's a good procedure, it's got a low complication rate, the expectations we're going to be able to turn your dog basically to normal. And then I tell people that there are options as far as how the procedure is logistically done. And so we use a biometric system here. And this is what's called a combination system. So you can use cemented implants or cementless implants. I'm going to explain what that is, and we've got a video at the end of this that'll even show it more. But basically, we're able to use a hybrid system that gives us some flexibility as far as what implants we put in, and it gives you flexibility at the time of the surgery. So you can cement it, you can not cement it, just kind of on the fly. This is what the box looks like. So there's cemented implants and there's cementless. So cemented is polymethyl methacrylate cement, and this is logistically what the implants look like. I've got bags of them up here. You guys are welcome to come up and look at them and whatnot. But basically, this is the femoral stem, and this is the neck portion, and this is the stem portion. Right here, there's a modular head, that little stainless steel ball that goes on the end, and this is a modular neck, so that basically all these necks, all the heads have a 17 millimeter diameter for the most part. And you can change the neck length on them depending on what different size you have. And basically the way that works is that, like, all the balls are the same size, but where the neck goes into the head, the depth of that hole is variable. Some of them have a shallow hole, some of them have a very deep hole. So if there's a deep hole, then this ball just slips onto this neck further down and makes the neck shorter. It's a polyethylene cup here. This little metal wire is just a radiographic marker. The thing about these implants is that they have grooves and structure to them. So, like, say for example, right here, right here, these are really kind of rectangular implants that are going to be embedded in cement, and they've got structure to them, so that creates rotational stability where the things don't want to move around because the cement totally surrounds them. And the same thing with these little grooves that are in the cup that goes into the acetabulum. So that's the cemented system, which is called a CFX. And then there's a cementless system, which is called a BFX. And so the cementless system involves no cement, and this is basically what's called a press fit. And so that means that when you do the procedure, you have to create a cavity within the femoral canal and a cavity within the acetabulum. When you do a cementless system, you have to make the hole exactly the size of this implant. And it's actually, the hole's a little bit smaller than the implant is, and so you have to like pound it in, and it's a press fit. These implants rely for their long-term stability on bone ingrowth, so this is more of a biological system. These are these hydroxyapatite kind of coating that goes up here. It's a rough coating that has little kind of pebbles on it, and the same thing here. And so the bone actually grows into that, and then those implants are stuck in the long term by this bone that's cementing the implant to the bone. So this is a more biological system. The trend is definitely goes. The general thought process is if you can do this, you want to do this, but there are certain reasons that you can't in specific situations. And the cementless and the cemented systems, they can be interchanged any way you want to. So you can use a cemented cup on a cementless stem, or etc. These are just some X-rays of. So this is a BFX system here, and so this shows again this femoral stem being advanced down into the femur. You can see how big it is. It's like there's no extra room in there, which Dr. Sullivan's like making a funny face because appropriately so, because you can fracture the bone. You have to be careful. The technique's real specific, basically, but this would be just the typical appearance. There's just a lot of detail that goes into exactly how these implants have to be applied, and you just got to really pay attention. But if you do, the procedure has been worked out, and it's quite repeatable. This is what a typical cemented system looks like, and so you can see how, relatively speaking, the size of the implant is undersized. And so you've got the cement that has to take up space, and then the implant's smaller, and you have to have like 2 millimeters of cement around the thing all the way around. There's a lot of details with the surgery as far as these things heading straight down the femoral canal, not touching the endosteal surface. There's a lot of different things. And then this is the radiographic wire marker associated with the acetabulum that helps you know what the orientation of the cup is, because you've got to put the cup in a specific orientation in order to maintain long-term stability. If it's put in an atypical position, then these things have a tendency to pop out of joint. And then this is just an example of a hybrid system. So this is, it's hard to see here, but this is a cemented stem, and then this is a cementless cup, right here. And so you don't have to make that decision before you go in. It's all in surgery with you, and you're like, you pick whatever you want to at the time, which is really, really nice. So since there are choices, there is a need to decide what are you going to use, and basically the evolution of the procedure is such that for the most part the acetabular portions are all going towards being cementless. The cementless cups can be applied to pretty much any dog, and there's some benefits. You can kind of modify the position of the cup, in surgery, and if you can avoid having all that cement in there, overall that's a good thing. The femurs, it's a little bit more complicated. There just are basically certain breeds of dogs that you can't do a cementless femur in. The giant breed dogs, and maybe they'll evolve the instrumentation over time, or the implants over time, to where they'll work. But the giant breed dogs, you pretty much have to cement their femurs. Shepherds have very different bone structure than most any other dog. They just have really, really big bones. They have thin cortices, and so they have to be pretty much cemented. The basic description is that in order to use this BFX stem, you have to have a substantial tapering of the femur as you come down into the middle of the canal. You can see how it's significantly wider here, and it gets quite thin. These big dogs, they have what's called a stovepipe femur, and so their femurs don't really taper down in the center of the bone. And so if you put a cementless stem in, what happens is that they get what's called subsidence, and their femur, the thing just falls into their canal. And so that's a lesson I'm glad I didn't have to learn, because they just have learned this through trial and error over time. Age is taken into consideration as well. I mean, typically young dogs, you're going to try to put a BFX or cementless system in. And then in older dogs, more often you're going to cement those. And that's because the thought process is the BFX system should have a greater longevity than the cemented system, whereas with really geriatric animals, they lose a lot of their kind of elasticity to the bone. It becomes almost coral-like and whatnot. So you can actually benefit those dogs by giving them the additional structural strength of having the cement within their canal. And again, you make these decisions on the fly, and there's certain kind of intraoperative things you have to take into consideration that you use to say which one you're going to use. This is just another example of that cemented. This is the difference between this tapering femur and then this more kind of, I mean, it tapers some, but it doesn't taper nearly as much as that other dogs did. So complications associated with total hip replacement. The reports are somewhere between 5 and 20%. Technique is really important with these dogs, basically, and it's really not all that complicated of a procedure once you have been able to go through the process. I mean, there's definitely some details associated with it, but it can be mastered basically just through practice and experience. For the most part, complication rates are reported at about 5%. Luxation's the number one, and that is typically felt to be relatively technically related, and that's generally associated with the acetabular position or orientation of that cup. I always go through the generic potential complications with the clients, and so I say anesthesia is a risk. It's really minimal. 1 out of 200 dogs or so will have major anesthetic problems. Incisional issues, it's reported in the literature, 3 to 4% of all dogs that have clean surgical procedures are going to have some sort of incisional complication. We take a lot of extra precautions with total hip replacements. We sterilize, we bleach the OR the night before. We've got special garb that we wear. We go through a different sterilization procedure for the leg, and so we spend a lot of time trying to knock that number down, which is very important to do. The Bizarro factor, which is I just make that up, and like dogs that have unrelated complications after surgery are complications that are totally unpredictable. They start to seizure, they throw a blood clot, they get pneumonia, etc. Just stuff that's kind of out of left field. Specific complications, infection. Again, you take a lot of specific effort to prevent that. It is a bigger deal with the CFX with all that bone cement. If they get infected, it is not pleasant. Because you generally can't get rid of that infection without tremendous effort. Luxation, that is equally as likely with either one of the systems. Implant loosening over time, really that's thought to be more of an issue with cemented systems. Now with the cementless systems, you got a window of about 6 to 8 weeks where they can loosen early, and you have to have them really tight or they will. But it's really thought to be more of a cemented issue. And then femur fracture, which this is actually a cemented stem, but because of the large size of that implant that you're putting in there and the fact that you're having to hammer it in as opposed to slide it in with some cement, femur fracture is a real possibility. I feel like that the technique has been evolved such that can generally be avoided through case selection, like cementing older dogs because their bone's more likely to fracture, and then paying attention to technique. So outcome, it's reported 85 to 95% success rate for the most part. I mean, for papers that are coming out in the last 5 years or so, they're really talking about 95 to 98% success rates, and really dogs that are going back to what's expected to be, normal outcome. They've got a very rapid return to function. This is a total hip replacement that we did when I was in my residency, and so that's a 1-day post-op with this dog that has bilateral hip dysplasia, but he's hiking. He's bearing weight on the operated leg, which the speed with which these guys' recovery is quite impressive, and they typically have very rapid recoveries. The expectation really is that if they have bilateral disease, the side that you do surgery on, it should be their superior side. Most dogs do not have bilateral surgeries performed. I think the tendency towards that is highly dependent on an owner. So if an owner is focused on pain control, which so many of the people that come here, that's what they're talking about. I mean, they're like, they can't stand the thought of their dog being in pain. And for a lot of people, they will go, well, he's still got a hip that hurts him, and I want to do the second side. But if you can, I tell people that if you can give a dog 3 good legs and a spare, then they should be much more functional than to have 2 good legs and two spare legs. So if you can give them 3, then generally that'll result in the improvement you're looking for. Okay, so last slide's just kind of a recap. We talked about hyaline cartilage and my obsession with it, and we talked about weight loss, which is, again, I feel extremely, you can get kind of hung up on talking about surgeries and whatnot, but like the power of weight loss just can't be overemphasized. With elbow replacements, there's a lot of unknowns, no proven technique. There is, the latest thing is this unicompartmental trend, and we'll see how that plays out over time. For knees, they're still quite early in the development of the replacement systems, but I can see there being room for knee replacements in the future. And then the hip is clearly, it's a proven procedure. There has been a continual expansion of application associated with it. I feel like I almost missed a slide, but the big point here is that there is a really high expectation as far as outcome goes.